Hi, this is Lisa, and this is the chapter review video for chapter 14, Reproductive Systems. And I know you're all ecstatic that this is the last video review that you have to watch for the class. So as we do with at the beginning of each of these video reviews, we look at the combining forms. And we're going to be looking at these as the male and the female reproductive systems. We'll talk a little bit about the same things, but then we'll talk about the male reproductive system and then go into the female reproductive system. So when we look at genitalia, these are the organs of reproduction and their associated structures. And you'll see what we mean as we look in each body system. External genitalia are going to be the things located on the outside of the body. Internal genitalia are the reproductive organs that are located inside the body. The perineum, this is what my husband always calls the taint because it taint the front and it taint the back. But the medical term for it is perineum. In the male perineum, it extends from the scrotum to the area around the anus. And in the female perineum, it extends from the pubic symphysis to the area around the anus. The primary function of the male reproductive system is to produce sperm and get them into the body to create new life. So when we talk about the male external genitalia, we're looking at the penis and the scrotum. And within that scrotum, there are generally two testicles. We will be talking a good bit about internal male genitalia shortly. So when we look at the male reproductive system, the one thing that we have to remember is this system is shared partially with the urinary system, which is not true in the female reproductive system. So we're seeing the bladder here, right here. We see the urethra, or the ureters here, excuse me, the ureter here. And then we see the urethra that's going to the outside of the body. That urethra is shared between the urinary system and the male reproductive system. That is why for males, a urologist deals with male reproductive issues as well as urinary issues. We'll be talking about all these little things later. This is a frontal view. Again, you can see here is the bladder. The ureters are coming in, one from each kidney. And then we see the prostate, which sits right below that bladder, where the urethra goes through to the outside of the body. Okay. Here are our testicles. We have our epididymis that sits on top of the testes. We have the vas deferens that come up and deliver our sperm as men are about to ejaculate. We have something called the seminal vesicles. We have an ejaculatory duct. We also have the bulbourethral gland, which is here. And we have these seminiferous tubules inside the scrotum or the testicle. All of these things help move the sperm. They're all part of the ejaculate. It's not just sperm. We need other things in there that these ducts and these vessels are going to be contributing to the semen. So a scrotum is a sac-like structure that supports and protects the testicles. It is suspended behind the pubic arch and behind the penis and lies between the thighs. Testicles are egg-shaped glands, and that's where those sperm are produced. They develop within the abdomen of a male fetus and then normally descend into the scrotum before or soon after their birth. And that's important because we're going to be talking about sometimes when they don't descend. The seminiferous tubules within the testicles is where the sperm is formed. And the epididymis is the upper part that sits on top of each testicle. And then it's kind of going to be where the sperm are stored and then moves up to merge into the vas deferens. Again, testicles, we have the spermatic cord. They're attached to each testicle, extends upward from the epididymis, and this spermatic cord contains vas deferens plus the arteries, veins, nerves for each testicle. And we all know that there's a lot of nerves, because if we get anywhere near a testicle, men get very upset with us, okay? So semen formation, the semen is a whitish fluid containing the sperm, which are the male gametes. Males ejaculate through the urethra, and what happens is, as the male gets ready, and we'll be talking about this, all of those pieces of the ejaculate come together to protect the sperm and to help them get to move where they need to go. So spermatogenesis is the process of sperm formation. There is an ideal temperature for sperm formation, and it's 93.2 degrees Fahrenheit. This is why the testicles can move, because if men are cold, the testicles are pulled up closer to the body to maintain that 93.2% or 93.2 Fahrenheit temperature. If their body is warmer, they will drop below the body so they can maintain that temperature. It really is quite interesting. This is one of the things when we're going to be talking about infertility. This is one thing that men are told if their sperm formation is not good, that they may decide to wear boxer briefs instead of tighty whities, as we call them, because the underwear that keeps them close to their body doesn't allow the testicles to work properly, to drop and move, so the temperature is correct for the sperm. So if they wear boxers, there's a little bit more room for nature to take place. Sperm moves from that seminiferous tubule in the testicle where the sperm is developed into the epididymis. And this is where they become motile, and they can move, and they're stored. From the epididymis, the sperm then travel to the vas deferens. There, the seminal vesicles and prostate gland add secretions to form semen. So all of those things are necessary in the formation of semen. So when we look at the penis, it is the male sex organ. It is what transports sperm into the female vagina. There's actually 3 columns of erectile tissue that are there, which is pretty amazing when you think about it. High pressure leads to the filling of those erectile tissues with blood during sexual stimulation. So again, the blood has to be able to get into that tissue to be able for the man to get an erection. The glans penis is the sensitive region at the tip of the penis. And the foreskin is actually a retractable double layer of skin that covers and protects the glans penis. It's also known as prepuce, and this is one of the things when when an infant boy is circumcised, they are removing the foreskin. In some cultures and for some people. Again, they do that for cleanliness. Some religions, some cultures don't believe in that. So it just is very important that because the skin moves up and over the penis and down, that it's kept very clean so we don't have an inflammation of the glans penis. Again, the vas deferens is a long, narrow continuation from each epididymis. It leads upward and joins the urethra. The seminal vesicles, they're at the base of the urinary bladder. They open into the vas deferens, and the seminal vesicles actually secrete a yellow substance that nourishes the sperm cells to give them the energy to go from the vagina to be able to swim up towards the egg and fertilize it. The ejaculatory duct begins at the vas deferens, passes through the prostate gland, and empties into the urethra. The reflex action then pushes the semen into the urethra and out of the body through the penis. The prostate gland lies under the bladder. It totally surrounds the end of the urethra where the vas deferens enter. Okay. The prostate gland secretes a thick alkaline fluid into the semen, which helps aid motility during ejaculation. So again, one more piece of the ejaculate that's needed in order for the sperm to get to the egg to fertilize it. The bulbourethral, boy, I'm not saying that right, glands are located just below the prostate. Again, they open into the urethra. They secrete a pre-ejaculatory fluid, and that is there to help flush any residual urine or any type of foreign matter that may be in the urethra. This is important because this is where people get in trouble. They don't believe that that pre-ejaculate fluid has any sperm in it. It may contain sperm. It just depends. And people can get pregnant even if they feel that they did not ejaculate into a female, that if any type of that pre-ejaculate fluid went into the female, there is still a possibility that there could be fertilization of the egg. The urethra then passes through the penis and to the outside of the body. And then again, we talked a little bit about that. This is both reproductive and urinary systems in the males. Hence, we go to a urologist. And they are the ones who specialize in diagnosing and treating disorders of the genitourinary tract for males and only urinary systems in the females. Pathology of the male reproductive system. This is balanitis, is actually the inflammation of that gland's penis, and we talked a little bit about this. This could be due to poor hygiene if the person isn't circumcised. We see this a lot in older males because, again, as people get older, they don't take care of themselves maybe as much as they should, so that they can get a very thick white, almost a fungus-like infection in there if they're not cleaning that gland's penis. Phimosis is actually the narrowing of the foreskin, preventing the retraction of that foreskin to expose the gland's penis. This can be present at birth, or it become apparent during childhood. That is a problem that will need to be taken care of. We also have erectile dysfunction. That is the inability of a male to achieve or maintain an erection. There could be a number of reasons for this. Remember, we just talked about there's 3 layers of tissue that have to have that blood be engorged in blood in order for them to have an erection. Peyronie's disease is actually when the penis is bent or curved during that erection, and it can actually lead to sexual dysfunction. Priapism is actually a painful erection that lasts more than 4 or more hours. That's not accompanied by sexual excitement and doesn't diminish after sexual stimulation ends. This could be due to medications or disease, but this is extremely painful for men. Extremely. So that blood, it's like the valves won't open to let the blood drain. Usually if somebody has that erection for 4 or more hours, they are going to be coming into the emergency room and seeing what's wrong. Premature ejaculation is just an early climax, usually before or shortly after penetrating the female's vagina. Testicles and related structures pathology is andropause. It's a decrease of testosterone. It begins when a man is in his late 40s, and that can cause a little bit of decrease in sexual drive. There's also cryptorchidism, and this is that undescended testicle that we talked about. Crypto means hidden. Orcho is testicle, so it's that undescended testicle. It could be a developmental defect when the child was in utero. It's very easy to fix. They usually can go in and help that descend. Anorchism is actually the congenital absence of one or both testicles. Epididymitis is actually the inflammation of the epididymis, which again sits on top of that testicle. And hydrocele is a fluid-filled sac in the scrotum leading from the testicles. So it's a problem where we get a swelling in that area. And we have some pictures here. So here's the epididymis, and this is epididymitis. It's inflamed. We don't need it to look like that. It generally looks like down here. This is where the testes are inflamed. And they're saying this is varicoceles, but we could also have the hydroceles here as well. Spermatocele, again, is a milky fluid-filled cyst in the epididymis. And we can also have issues with testicular cancer. It's most common in American males between the age of 15 and 34. This is why men should be doing, just like women do self-breast exams every month, men should be doing testicular self-exams every single month. Because by the time you can feel a difference or a knot in the testicles, you're pretty progressed. So it's really important that you're checking that to make sure that everything's okay. Testicular torsion is when there's actually a twisting of the vas deferens and blood vessels into the testicle. If that is not fixed immediately, the man is going to lose that testicle. And it has to be done quickly. 24 hours, you actually would have some probably tissue death, and they would have to remove the testicle. So it's important to get in there, that you feel it, it's uncomfortable, and you just need to get into the doctor or the emergency room to have that checked. Testitis is going to be the inflammation of one or both testicles, excuse me. And varicoceles are a knot of varicose veins in one side of the scrotum. And just like varicose veins on the leg, you feel them. They are uncomfortable. So when we're looking at sperm count, the normal sperm count is 20 to 120 million or more sperm per milliliter of semen. That is a lot of sperm. And that's what our bodies should be producing. Azoospermia is the absence of sperm. Oligospermia is a sperm count below 20 million. And hematospermia is we're going to see blood in this seminal fluid. This can be caused by a number of different things. It can be an infection in the seminal vesicles. It could be prostatitis. It could be urethritis or urethral strictures. There's a number of reasons. It's not always reproductive produced. It could be because of a urinary issue as well. So the diagnostic procedures that we see in male reproductive system is going to be the sperm count. They're going to get a sperm sample. They're going to actually look at them, count the number of sperms, and see if they're not only the number, but the shape of them, the size, and motility of the sperm. All of these things play a piece in fertilization. If you have a lot of sperm, but they don't have that little flagellum at the end that moves back and forth to help them get to the egg, then it's not going to get there. They have a short period of time to get from point A to point B. And so it's important that we look at the number, shape, size, and motility to see if indeed there is an issue with the sperm. And again, testicular self-exam. This is so very important. If you guys out there are listening, please make sure you're doing that. For the ladies out there listening, please make sure you encourage your significant other or brothers, whoever's out there that's male that you know, that they need to do that if they're in that age bracket, because if we can catch it early, they can get the testicle off and it goes no further. So you need to really be careful and be monitoring that. Some general treatment procedures in the male reproductive system is the circumcision. And again, they're removing that foreskin on the penis. They usually do this a day after birth. In some traditions, it's actually a ritual that's done by a religious leader, and it's a celebration. So some of those things come into play as well. Orchiectomy is a surgical removal of one or both testicles. Orchiopexy is actually the repair of an undescended testicle. And a varicocelectomy is actually the removal of portion of an enlarged vein to relieve that varicocele. Castration is a surgical removal or destruction of both testicles. Vasectomy is male sterilization. What they do is they go in, they cut out a small portion of the vas deferens, which prevents the sperm from being able to enter into the ejaculate. So you still have ejaculate from the prostate and the seminal vesicles, all those different things. It just doesn't have sperm in there, okay? Vasovasotomy, again, it's an attempt to do a reversal of that vasectomy. They have to go back in, find the two ends of the vas deferens, sew them back together, and hope that everything works. Sexually transmitted diseases. These are going to be either bacterial or viral diseases. They're generally caused through sexual intercourse or genital contact. Chlamydia, it is highly contagious, and it requires early treatment with antibiotics. This is a real problem with people, because if a woman's diagnosed with it, they need to tell their partner. They both need to be on antibiotics for a period of time, restrained from having sex, because it's very easy to give it back and forth to each other. And so it really needs to be treated early, and hopefully you're not spreading it back and forth. Bacterial vaginosis, it's going to occur in women due to an abnormal overgrowth of certain bacteria in the vagina. Genital herpes, again, very contagious. This is where you're going to see lesions on the genital areas or the rectum. There is no cure for this. It will not go away. And you can use antiviral drugs to decrease the symptoms, but they will always be there. In some cases, you can get the lesions to disappear, but it's always something that you have to remember, because this can be transmitted to somebody else. So this is a case where you're going to have to wear some type of protection as far as a condom, because that could be transmitted very easily into a male or female. Genital warts, again, are highly contagious, caused by human papillomavirus. There is now an HPV vaccine that's available. For years, they only said it was necessary for women, but now they're having men get it as well, or in the children's immunization schedules. It's now built into both male and female immunization schedules. Gonorrhea, again, is highly contagious. It can affect your mouth, your throat, your anus, as well as the reproductive organs in males and females. Nasty stuff. HIV, or the human immunodeficiency virus, again, we know is transmitted through exposure of infected body fluids. And so we have to be careful with that. Syphilis, again, highly contagious. It's transmitted from person to person through direct contact or a canker. A canker sore is like kind of like a cold sore that opens and oozes. Okay. A lot of times this is very difficult to distinguish from other STDs that are out there. They will do a swab and they will look at that under the microscope, as well as send it off to be tested to make sure that that is what it is. They will be giving you treatment immediately, but depending on what they find, they may have to change that because if it's not syphilis and it is one of the other STDs, they may need to change medication to, to something that's more, that will be more effective. Trichomonas is an infection caused by a parasite. And again, it can affect both males and females. So now we're going to jump into the functions of the female reproductive system. Again, it's there because we are creating and supporting new life. We have ovaries. They produce mature eggs to be fertilized by the sperm. We have a uterus that provides the environment and support for developing the child. And then our breasts produce milk to feed the infant. So again, functions of the female reproductive system. You'll see here's the bladder and here's the urethra. We don't have anything to do with that in the female reproductive system. Behind it, posterior to the urethra, is going to be the vaginal opening. Okay, here's the cervix. Here is the uterus. You can see here that is the fallopian tube, and our ovary sits here. Okay. So our external female genitalia is located posterior or behind the mons pubis. Its structures are collectively known as the vulva, but we have the labia majora and the labia minora. And what that does is protect external genitalia and the urethral meatus. The clitoris is the erectile tissue of the female. Just like the penis is the erectile tissue of the man, the clitoris is that of the female. The Bartholin's glands help lubricate the vaginal orifice, and the vaginal orifice is the exterior opening of the vagina, partially covered by the hymen. And you can see here, the mons pubis is here. You can see the Bartholin's glands, the clitoris, the labia majora and the labia minora, all there. Breasts are made of fat and connective tissue and mammary glands. Sometimes breasts will be categorized in the endocrine or exocrine systems as well. They are milk producing, the mammary glands are milk producing glands that develop during puberty. The lactiferous glands carry the milk from the mammary glands to the nipple. And the areola is a dark pigmented area surrounding the nipple. So you can see here are the mammary glands. You see the lactiferous ducts that are taking that milk out to the nipple so we can feed that baby. Internal female genitalia are located within the pelvis and protected by our bony pelvis. We have two ovaries. They're small almond-shaped organs located in the lower abdomen on either side of the uterus. There are follicles. They are fluid-filled sacs containing a single ovum. Now, the cool thing with this, those eggs are developed in utero. So you have all the eggs you need as you are developing in your mother's uterus. The ova is the female gamete which is the gamete, which is the egg. We have two fallopian tubes. They end from the upper end of the uterus to the point near where the ovary is. They're not attached to the ovary, but their opening is by the ovary. What these fallopian tubes do is carry the sperm up from the uterus towards the descending mature ovum to allow fertilization. So, excuse me, again, and we'll see a picture of it here in just a minute. Those fallopian tubes is where fertilization takes place. The infundibulum is the funnel-shaped opening of the fallopian tube near the ovary. And the fimbriae are like fingers that extend to catch the mature ovum when it leaves the ovary. So as we can see in this picture, these are the fimbriae right here. You can see what happens is the ovaries are here. There's a little bit of space here between those two. The ovum leaves and travels up through the fallopian tube, down. At some point, it will be fertilized here. And as it travels down, then it will travel down into the uterus and will attach to the wall of the uterus. And then that is, we have a fertilized egg. Okay. The uterus is pear-shaped and it's muscular walls and has a mucosal membrane lining. It's located between the bladder and the rectum. And the normal position is antiflexion, which means it bends forward. Okay. The fundus is the round top part where the fallopian tubes come in. The corpus, which is the middle portion, and it's the body of the uterus. And then the cervix is the lower narrow portion that extends into the vagina. There's three different major tissue levels. So there's the parametrium, which is the outside layer, the myometrium, which is the middle layer, and the endometrium, which is the inner layer, and that's where there's very, very rich in blood vessels. So I'm going to go back to this picture for just a second, and you can see, here's the parametrium, here's the myometrium, that's that muscular part, and the endometrium is that internal lining. And that's what's going to slough off and cause a period or a menstruation if we don't have a fertilized egg. Okay, so again, here's the fundus, here is the interior piece, and here is the cervix down here. Okay. The vagina is a muscular tube from the cervix to the outside of the body. Again, it's lined with mucosal tissues. And when we talk about menstruation, again, what happens is during, if we have an unfertilized egg, then what happens is the lining of the endometrium will slough off, and that's when we get menstruation, usually every 28 days. So menarche is actually the first beginning of menstruation ever, their first period ever. The average age is about 12 years old in the United States. Now, you will see some younger girls have a period. You will have them not have a period, their first period, until sometimes they're older. Everything is different. Everybody is different, so you may see that at different ages. Menopause is the normal termination of menstruation during our middle ages. And again, they say the earlier your periods start, the later menopause hits. I don't know if there's any real correlation to that, but you will know after you have not had a period for a year, that's what they consider menopause. Perimenopause is that transition between having regular menstrual periods and no periods at all. Ovulation, that is the release of a mature egg from the follicle in the ovary. It occurs on the 13th or 14th day of the menstrual cycle. What happens then is that corpus luteum secretes progesterone during the second half of the menstrual cycle to help maintain the growth of the uterine lining in preparation for that fertilized egg. So after the 13th and 14th day, and that egg is released, the corpus luteum buffs up our endometrium because it's waiting for a fertilized egg. If it doesn't take place, then that endometrium sloughs off, and that's when we have our period. Now, if it's fertilized, conception occurs then when that sperm penetrates the fertilized ovum. A union of a single cell is known as the zygote. That implantation is when that zygote embeds into the uterine wall. Embryo is from implantation to the 8th week of pregnancy. After the 8th week of pregnancy, that's when that is called a fetus. So from the 9th week of pregnancy to the 40th week or time of birth, it's considered a fetus. We can have multiple births, and the fraternal twins, these are actually two separate ova that were fertilized by sperm, but there are two separate embryos. Where identical twins are a fertilization of a single ova by a single sperm that divide into two embryos. So fraternal twins can be a boy and a girl, it can be two girls, but they're not going to be identical. If they are identical twins, they're going to have the same sex, and they're going to have this same genetic information from those parents. You can see here is the fetus. It is the umbilical cord is here, and that is going into the placenta, which is the lifeline for that fetus during pregnancy. We can see the cervix is here, and the vagina is there. Now, this cervix we're going to be talking about shortly is right now that baby can't get through that because it's not open. And we're going to talk about the effacement and dilation of the cervix when we get ready for birth. The chorion is the outermost membrane that encloses the embryo, and that chorion contributes to the formation of the placenta. The placenta then is actually considered a temporary organ in our body within the uterus that allows the nutrients, the oxygen, waste products between mom and fetus to keep that baby alive without allowing the mix of maternal blood and fetal blood. So there's not a mix of maternal blood and fetal blood at this point. The amniotic sac is the innermost membrane that surrounds the embryo in the uterus. That amniotic fluid protects the fetus and allows for that floating motion as they grow. The umbilical cord carries the oxygen, blood, nutrients from the placenta to the fetus, and it also transports waste from the fetus to be disposed of through the mom's excretory system. Once the baby is born, the cord is cut, and then they deliver the placenta. You've probably seen that. They clamp the umbilical cord, they cut between the two clamps, baby goes over to the warmer, and then at that point the baby is no longer any concern of the obstetrician. The mother is the obstetrician's only patient. Once that baby's born, there will be a pediatrician or a neonatologist at the warmer, and they are responsible then for the baby, not the OB. Gestation, it takes about 280 days or 40 weeks. We divide that into 3 trimesters. What we do is our due date is calculated from the first day of the last menstrual period. So that LMP is going to be a abbreviation that you need to know, because what they do is they're looking for that LMP to determine the due date. Quickening is when we first feel the baby move. Braxton Hicks contractions, they're intermittent contractions that occur during pregnancy. It's really helping our body and the uterus to get ready for delivery. The term viable means that the fetus is capable of living outside of the uterus. And antepartum is the final stage of pregnancy just before the onset of labor. Now, terms that you're going to hear during pregnancy. Nulla gravida is a woman who has never been pregnant. Nullipara is a woman who's never born a viable child. Now, you can have somebody who is nullipara, or you can have someone who has been pregnant, but they have not born a viable child. They may have been pregnant, but they lost the baby somewhere. They had a miscarriage. Okay. Prima gravida is a woman during her first pregnancy. Primiparia is a woman who's given birth to a viable child for the first time. And multiparous is a woman who's given birth 2 or more times. Okay. Parturition is labor and delivery. Again, there's 3 stages. There's dilation, there's delivery of the baby, and then expulsion of the afterbirth. So you can see here, they make it look so easy. Doesn't she look peaceful? So the placenta is at the top, hopefully, or it's on the side. As the baby is in a head down position, it will start to help dilate the cervix. And we talked a little bit about that. So the cervix is dilating, which is opening bigger, but it's also thinning. And so it thins and opens for the child to be able to pass through. You can see it's just starting here. Here it's opening and it's allowing the baby to go through that cervix. After the baby's born, they're going to clamp that umbilical cord, give the baby over. Then the mom is going to have to deliver the placenta afterwards. The first stage of childbirth, of course, is the longest. It includes the dilation and effacement of the cervix, usually rupture of the amniotic sac as well. So effacement is that shortening, softening, and thinning of the cervix. Fetal monitoring, they'll put just like a strap with a monitor on mom's belly to monitor the fetal heart rate and the contractions during labor. And this is really important because if they start to see the fetal heart rate go down with contractions, that's really a concern, because that means that the baby may be in distress. So they'll watch that very carefully. And if that baby's heart rate continues to decrease over, a shorter period, over a period of time, that mom's probably going to go in for a section, because they're afraid if they deliver, there may be something that, the cord may be wrapped around the baby's neck. There could be an issue that they're just not sure of. The second stage begins when the cervix is dilated to 10 and is ready to go and deliver that baby. And then the third stage is delivering that placenta. Postpartum means after childbirth. I am going to go back to the picture one more time because I do want to mention one thing. And I hate to make you sick by doing that. But the placenta is generally here or on the side. Okay, wait, there's a better picture, I think. And I just went through it. No. But I'm trying to find the better picture. Well, apparently I'm lying. It's only one picture. So what will happen if you have something called placenta previa? The placenta is covering the opening of the vagina and the cervix. That is something that's very dangerous. We can't, if the placenta is born before the child is delivered, before the child is no longer getting any oxygen or any nutrients to the baby. And so anybody who's placenta previa is going to need to have a section. Now, the one thing is, if you're in early pregnancy and they say you have a partial placenta previa, what happens as the baby grows, the placenta may go up a little bit. And so the placenta may be sitting here and you're able to have a vaginal birth. But if you guys aren't looking at this, and I am. Okay, so if you can see, so here is where the placenta previa would be. It would be over the opening, and it would have to be delivered before the baby. That's a no-no. But if it's here, if it's just partially here and early in pregnancy, as the baby develops, it will kind of bring it up, pull it up a little bit as we start to get larger. And so you may, if you have a partial previa, you may be able to deliver vaginally. Okay. Sorry, I could see it on my screen, just couldn't see it on yours. Postpartum means after the childbirth. Puerperium is the time from delivery to the time of to 6 weeks, which is normal, the normal time that takes usually to get back to normal. The lochia is the postpartum vaginal discharge that continues between 4 and 6 weeks after childbirth. We watch that. We want to make sure that it's not has any color or has any smell, because there may be infection if we see that. Uterine involvement, that's the, involution, gosh, is when the uterus returns to its normal size and normal condition. Colostrum is that first, it's that first milk that comes from the breast. And this is really, really important, because this is delivering to that baby nutrients and antibodies from the mom. So it's a very light colored, almost whitish type fluid, but that colostrum is really, really important for babies to have to help with their immune system. And again, this is produced during late pregnancies and the first few days after birth. Lactation is the process of forming milk and secreting milk from the breasts. After a few days after giving birth, the colostrum will then be replaced by breast milk. Postpartum depression. This is something that women will have. Again, your hormones are going crazy. You know, you've had tons of estrogen, some progesterone, you got all this stuff going on. And now your body is trying to get back to normal with those hormone levels. And sometimes that abnormal hormone level causes postpartum depression. And that's going to be somebody who feels very sad or loss of pleasure in activities after giving birth. And they do treat that very similarly than they would treat regular depression. In the baby, the neonate is the newborn during the first 4 weeks after life. The vernix is that greasy stuff that comes that protects the fetus in utero, and it can be present at birth. It's like the white greasy stuff that comes out with the baby. Meconium is different. Hopefully we don't see meconium when we deliver the baby. If that water breaks and we see a greeny, like green in the amniotic fluid, we're concerned, because that meconium is really the baby's first stool. And if that meconium, if they have that first bowel movement in utero, that has been in the amniotic fluid and it's been lining the baby's lungs. And what can happen is we call that meconium aspiration. And what can happen is they can develop a terrible infection, a respiratory infection because of that. So we always hope that that's not the case. They deal with it when it happens. They'll treat the baby and just make sure that it's suctioned out very well. If it doesn't happen in utero, one of their first few bowel movements is going to have that very green, pasty looking stuff. APGAR scores are a scale of 1 to 10, and they're done at 1 minute and 5 minutes after birth. You want a score of about 8 to 10 for both. And what they're graded on, there's 5 criteria, and you get a 0, a 1, or a 2 for each of these categories. So they're going to look at the baby's heart rate. They're going to look at the baby's respiratory effort. Okay. They're going to look at the muscle tone of the body. They're going to look and see if they're responding to stimulus. And they're going to be looking at skin color. Are they nice and pink? Are they still a little bit blue? So even if we have a lower score at 1 minute and then we get a nice score at 10 minutes, that's a great thing to see. Medical specialties related to female reproductive system is going to be the gynecologist, which is diagnosing female reproductive. Obstetrician is the person that takes care of pregnancy, childbirth, and postpartum. Neonatologist is someone who diagnoses and treats disorders of newborns. A neonatologist is usually 0 to 28 days. Pediatricians are then as they get older. In many cases, we just have pediatricians that see the newborn if there's no difficulty during delivery and the baby's doing well. But if there may be some issues that they're worried about, they would call a neonatologist in just to make sure. And we also have infertility specialists for people who are having difficulty with conceptions and maintaining pregnancies. Okay, so different pathologies of female reproductive system. We have the of the ovaries, the fallopian tubes, and ovulation. And ovulation is the absence of ovulation when normally expected. Menstruation may continue, but there just may not be an egg that should be there. Oophorytis is an inflammation of the ovary. Ovarian cancer, this is when the cancer originates in the cells of the ovaries. Hard to find. Again, so that's why we do testing to make sure everything's going okay. Pelvic inflammatory disease, PID, is an inflammation of the female reproductive systems, usually caused by complications of an STD. Polycystic ovary syndrome, this is when we get a lot of cysts on the ovaries. And what that happens then is the follicles don't develop. And then we're not able to have developed eggs going down the fallopian tubes to be fertilized. Salpinx is accumulation of pus in the fallopian tubes. Salpingitis is it's an inflammation of the fallopian tubes. Endometriosis it's when parts of the endometrium, which should be in the uterus, actually escape and they attach to other structures in the pelvic cavity. This causes a lot of pain and can really affect the ability of people to get pregnant. Endometrial cancer, again, that is when the cancer starts in the uterine lining, that first layer, and can be problematic. Uterine fibroids are just tumors composed of muscle and fibrous tissues inside the wall of the uterus. Generally not cancerous, but they can be problematic for people that are trying to get pregnant, and they can also be painful. Uterine prolapse is It's when the uterus slides from the normal position and actually extends down into the vagina. And there's a number of different things that we can do for that. We can use we can do sling surgery, so it kind of holds it back up in place. And we can also use other devices that help hold that in place. We also have cervical cancer. Again, it's a slow-growing squamous cell cancer. This is why we go in and get pap smears, because they're testing for this. Okay, cervical dysplasia is the presence of precancerous changes in the makeup of the inner lining of the cervix. So you may hear, well, there is some dysplasia going on. We need to do another pap smear in 6 months. That's why. They may have found some precancerous changes and they want to watch that a little bit closer. Cervicitis is the inflammation of the cervix. And endocervicitis is actually the inflammation of the mucous membrane lining the cervix. I didn't know I could do that. With a vagina, excuse me, colporexis is actually the tearing or laceration of the vaginal wall. Dyspareunia is painful sexual intercourse. And then leukorrhea is the whitish mucus discharge from the uterus and the vagina. Vaginal atrophy, that is the decrease in elasticity and lubrication, and it's related to hormonal changes. A lot of times you'll see this in women who have gone through menopause. Vaginal candidiasis is actually that yeast infection of the vagina. We've all had it. I'm sure, no, well, maybe not if you're a guy, but it's just a yeast infection. Remember, every part of our body there's a homeostasis there. And the bacteria are there, but they're there in the way they're supposed to be. There's, nothing can grow outside of it. The minute we put something, or we even change something like an antibiotic, it kills off some of the good bacteria in the vagina and allows that yeast-like infection to take over. And that's what happens. So a lot of times when you get an antibiotic, they'll give you medication to prevent that, or they will tell you to take acidophilus, because the acidophilus is similar to the bacteria in the vagina that we need for that equilibrium. So that can be a real issue. So we have vaginismus. And that's the involuntary spasm of the pelvic floor muscles. When we look at the external genitalia, we have pruritus vulva. Again, that's severe itching of the external female genitalia. And we see that a lot of times with that vaginal infection, that candidiasis. Vulvodynia is pain in the vulva, and vulvitis is an inflammation. Different pathologies with breasts are going to be fibroadenoma. It's a firm breast rising from the extensive growth of granular or connective tissue in the breast. So they'll look at that and make sure that there's no cancer with that, and they can always remove the tissue. Fibrocystic breast disease, again, people who have single or multi-benign cysts in the breast. Galactorrhea is the production of milk in women who are not breastfeeding. And one of the times we see this, and we talked about this in just one of the past chapters, when we have an issue with the pituitary gland, and a pituitary adenoma will sometimes trigger this galactorrhea. Okay. Mastalgia is pain in the breast, and mastitis is an infection in the breast and inflammation, so to say. And we see this a lot during breastfeeding. Menstrual disorders, we're going to see amenorrhea. That means we have an absence of the menstrual period for 90 or more days. Dysmenorrhea is painful uterine cramping during the menstrual period. And dysfunctional uterine bleeding is an abnormal bleeding due to hormonal level changes. Hypermenorrhea is an excessive menstrual flow for more than 7 days. Hypomenorrhea is a small menstrual flow. And menomenorrhagia is an excessive uterine bleeding, but this is between menstrual cycles, during the menstrual period and at other irregular intervals. So you may have a lot of bleeding during your menstrual period, but then you may have it irregular bleeding as well between periods. So there's other menstrual disorders. Metrorrhagia is, again, bleeding between menstrual periods. Oligomenorrhea is going to be infrequent or light menstrual periods. And polymenorrhea is going to be menstrual cycles occurring more often than normal before that 28-day cycle. Premature menopause. Ovaries cease functioning before the age of 40. This could be due to hormones, it could be due to disease, or it could be because they've had a hysterectomy with removal of the ovaries. Okay. Premenstrual syndrome, it's symptoms like bloating, headaches, just plain old nasty grumpiness during the 2 weeks before menstruations. Premenstrual dysphoric disorder is the emotional and physical problems linked with the menstrual cycle. Abortion is the interruption or termination of pregnancy before the fetus is viable. And the one thing is, we call a miscarriage a spontaneous abortion in healthcare. So you need to be careful when you're reading a medical chart that you're not making judgment calls on people if you see spontaneous abortion. It just means that they lost the baby in their early pregnancies. Anything actually before 20 weeks. Ectopic pregnancy is when the egg implants outside of the uterus, usually in the fallopian tube. This is very, very dangerous because it's still going to adhere, it's still going to grow, and it's going to look like the woman is pregnant. But what can happen is it can actually grow so large that it just blows out the fallopian tube. So it's never going to be a viable pregnancy. They usually will have to go and get that out if they determine that it's a viable pregnancy or an ectopic pregnancy, because we don't want to lose the function of one of the fallopian tubes, because then you'd go that every other month with trying to conceive. Infertility, the inability of a couple to achieve pregnancy after a year of regular unprotected intercourse. Preeclampsia is a nasty complication. It is hypertension causing and you have edema and proteinuria. Again, that's why they're doing urine dipsticks every visit on women who are pregnant. We're looking at the protein in the urine and we're looking at the sugar in the urine. Okay. Eclampsia is a serious form of preeclampsia, and that can cause convulsions and coma. So if the mom is diagnosed with preeclampsia, they are going to probably be placed in the hospital, be monitored, and if that blood pressure can't come down, they may deliver the baby because they're worried about the mom going into eclampsia. Pregnancy, the different pathology is called HELP. It's hemolysis, elevated liver enzymes, and low platelet count syndrome. It has You're going to find hemolysis, which is not great, elevated liver enzymes, and low platelet counts on this patient. It usually can occur during the third trimester of pregnancy or even after. It is something that needs to be dealt with immediately. It is life-threatening. Anytime you have hemolysis, it's going to be. Rh factor defines the presence or absence of the Rh antigen on the red blood cells. It can cause problems if the mom is HR negative with an Rh positive baby. And so that is marked from the very beginning. The treatment for that is RhoGAM. You'll get one, I think if I remember correctly, at 28 weeks, and then you'll get one at birth. Okay. Some of the other terms at childbirth, abruptio placenta. It was when the placenta separates from the uterine wall before birth. That can be life-threatening as well. They're going to deliver that baby ASAP so it doesn't go too long without oxygen. Breech means the butt and feet are first instead of the head. We want head down with face down for the baby to be delivered. Okay. Placenta previa, we talked about that. That's where the placenta is down at the bottom, kind of covering the cervix and the top of the vagina. And premature infant is a fetus born before the 37th week of gestation. Stillbirth is a birth of a fetus that's died before or during the delivery. Okay. One of those terms, once a baby gets past 20 months, you can, if the baby dies, they can go in and do D&C and be able to, take care of all that through a D&C. If the baby is between 20 and 22 months and it stops the heart stops beating, that is called a stillborn, and mom has to go through the birth of that child. Okay. A colposcopy is going in to visually examine the tissues of the cervix and the vagina. Endovaginal ultrasound, it can be, they can go in and they're going to try to determine the cause of abnormal vaginal bleeding because they're going to go into the vagina and look to see what's going on. Hysterosalpingography is actually going in, looking at, it's an X-ray type exam that's going to be looking at the uterus and the fallopian tubes. A hysteroscopy is when you go in and look at the uterus and the fallopian tubes. And a pap smear is what we do every year. And we go in where they get a biopsy of the cervix, of the cells, to determine if there's any type of cervical cancer. Pregnancy tests, again, HCG is the hormone that we're looking for. So if there's a high level of the human chorionic gonadotropin, HCG, in the blood or the urine, that's going to indicate pregnancy. Okay. First trimester testing, they're going to do an ultrasound to see if the baby is fitting in with a size and their LMP. They're going to do blood testing. And again, this is something moms can refuse if they would like, because it may be talking about detection of some type of their Down syndrome, any type of issues that the baby may have. There's a lot of moms that don't want to know, and so they just say, I don't really want to do this testing. Okay. They're going to be doing regular blood testing for H&H and those type of things throughout the pregnancy, but this first trimester testing is to make sure that the baby's okay, and going from there. Chorionic villa sampling, they actually examine the cells from the chorionic villa to detect genetic anomalies. They can perform this between the 8th and 10th week of pregnancy. Amniocentesis will be done usually after the 14th week of pregnancies. They go in, they would use ultrasound, and so to make sure they're not sticking the fetus, they will put a needle into the amniotic fluid, draw some out, and they can detect congenital disorders. So spina bifida, Down syndrome, number of things. Again, some people will, if they are concerned, they will do this. Other people, it's not a normal test that's done, but if that first trimester series of tests comes back irregular, they may do an amniocentesis. Pelvimetry. I'm telling you, I can't speak today. It's a study that measures the dimension of the pelvis to evaluate the capacity to allow the baby to come through the birth canal. There are some moms that have very narrow hips and they're not going to physically be able to deliver that baby. So they'll actually do a test to see if that's going to be able to. So there's a lot of different things that we can look at as far as treatments. Contraceptives, they decrease the likelihood of pregnancy. So things like the pill, those type of things. One thing to remember, if you are on any antibiotic, it counter affects your contraceptives. So I can't tell you, when I worked in OBGYN, how many antibiotic babies we saw. If you are on antibiotics and on the birth control pill, you need to use some type of other prophylactic measure, because the antibiotic has has reduced the efficacy of your birth control pills. There's also diaphragm, which is a barrier contraceptive method, and it just doesn't allow the sperm to reach the fertilized egg. And then we have an IUD, or an intrauterine device, that is inserted through the cervix, and it is there to prevent pregnancy. Condoms, again, female and male condoms. I am just telling you, if you are not monogamous, you should be using these because it really helps prevent the transmissions of STD, and hopefully will prevent pregnancy as well if you use them correctly. Hormone replacement therapy, we can use estrogen and progesterone to help replace those that are no longer produced during and after menopause. The oophorectomy is a surgical removal of one or both of the ovaries. Salpingectomy is the removal of the fallopian tube, one or more. Salpingoophorectomy is a surgical removal of the fallopian tube and ovary. Tubal ligation is like a vasectomy in men. It's a surgical sterilization. They're going to go in, they're going to cut the fallopian tubes, seal them, burn them together, whatever, and prevent the sperm from reaching a mature ovum. Colpopexy is the surgical fixation of a prolapsed vagina. Conization is actually a surgical removal of a cone-shaped specimen tissue from the cervix to test for cervical cancer. And colporrhagia is the surgical suturing of a tear in the vagina. Dilation and curettage. This is what they do if there is an issue with excessive bleeding. If you have a miscarriage, they'll go in and scrape. Remember, curettage is scraping. So they dilate the cervix, and then they go into the cervix and they scrape away that endometrial level to come out. Okay. Myomectomy is actually the surgical removal of uterine fibroids. A hysterectomy is a surgical removal of the uterus. A total hysterectomy is the removal of the uterus and the cervix. A radical hysterectomy is a removal of the ovaries, the fallopian tubes, the uterus, the cervix, and the nearby lymph nodes. Generally, this is when they've gone in, they found some type of cancer, and they're taking all the female reproductive organs as well as the lymphs so it doesn't spread. There's mammoplasty. Breast augmentation is to increase the size of the breast. We also have people who have very large breasts that want them reduced because it can cause major issues with the spine. So again, they're decreasing and reshaping large, heavy breast. And maxopexy is when they take saggy breasts and put them in more of an elevated position. C-section is where they deliver the baby through an incision. They open her up, either give her a general anesthesia, or they'll give her some type of spinal so she can't feel. They'll cut that open, and it's amazing to watch if you ever get the chance, because they are in there, that baby's out within minutes. It is absolutely amazing how quickly they do that. Episiotomy is an incision in the perineum to enlarge the vaginal orifice to prevent tearing as the baby is delivered. We're not seeing that done as much as it used to be. When I delivered, they did that. Now they're letting people tear. They're saying the tear, I don't understand it, but the tear, they can suture the tear, which is an episiraphy, and they can go, that's actually for the episiotomy, but they will go in and stitch up the tear, and they say that's better. I don't know. Speaking from a woman's point of view, I think if you have a nice straight cut and you stitch it up, I think that would be easier than a tear. Just saying. But incubator maintains the environment of a controlled temperature, humidity, and oxygen concentration for a premature baby or a newborn that may need a little bit of help. And then assisted reproduction. Artificial insemination is when sperm from a woman's partner or donor are introduced into the vagina or uterus during the ovulatory phase of her menstrual cycle. So this is not in vitro. This is artificial insemination. In vitro fertilization is when a mature ovum is removed from the mom to be fertilized outside of the body, and then they put a sperm with that ovum. That fertilize, they have an embryo, and then the embryo is transferred back into the uterus, hoping that's going to implant and continue as a normal pregnancy. Please make sure you're reviewing Chapter 14's abbreviations at the very end of the chapter, and that is it.